Well, it sounds like you have a great support system behind you. I want to get back to the study. Can you tell me about your findings?
Well, the most resistant form of precancerous disease is what we call high-grade disease. Okay, and this, it can go away on its own, but it can usually take a year or more, possibly up to 2 years.
Yeah, if I can step in, probably you can't have someone with high grade and then leave it and follow them and see if it goes away on its own.
No,
you just can't
because
of the risks of it developing into something far more serious, the risks of it developing into cancer. But if you go slightly one step down, so not quite as high grade, but getting there, they have followed those women and they found that it's probably around 17 months if you're going to get regression naturally of these lesions, and it probably happens in about up to 40% of women. So if they were left, 40% of women probably would go away or go to a lower level, and the average time would be about 17 months.
Okay, so we eventually managed to recruit 23 women with high-grade disease into the trial, and these were given one capsule twice a day for 2 weeks, which is, for this type of disease, is a very short period of treatment. And within 1 month, there was a very significant improvement. We tested them, we looked at their papillomavirus titer using the Hologic Cervista machine. We tested their cytology, which is looking at the presence of abnormal cells. And after 3 months, we did pathology as well, where you actually take a piece of the cervix and get this examined by a pathologist who will then tell you the extent of disease. After 3 months post-treatment, over 90% of the women, 19 out of 23, actually showed that had returned to normal, and 2, the disease had actually dropped in severity to what's called low-grade disease. So we got a response of over 90% in 3 months.
Yeah.
I want to congratulate both of you. That is an amazing success rate. Where do you go from here?
Right. Well, basically, we need funding. We desperately need funding because the next stage, we started off to do what's called a phase 1 trial. Phase 1 trials are normally where a drug's, if you like, tolerability or safety issues are addressed. Now, this drug is already licensed for use in humans. It's licensed for treating children. There's a pediatric formulation, a liquid formulation. But this was, of course, a different route of administration. So we wanted to see whether there were any adverse reactions to applying the capsule as a pessary. And I can tell you, we saw no adverse reactions at all. Dr. Maranga told me there were absolutely no complaints from any of the ladies we treated.
But then when we started to see efficacy, or simply we saw that the treatment seemed to be having a beneficial effect, what that means is that we have what's called phase 1, phase 2, phase 3 studies. So that started to move us into a phase 2 because seeing an effect is actually more than what a phase 1 study would normally be looking at. You're just looking, can the treatment be tolerated? You start to see an effect, that's fantastic. So what we need to do now is we can probably go straight to a phase 3 now, and we need to have a much, much larger number of women for that. And we also now need a control arm, so women who receive the treatment, women who don't, because we'll have to follow both of those arms independently and then look at the differences in results. And we need to do it in more than one centre. So not just say Kenyatta National Hospital, we would need an additional centre, so it's a dual centre study.
Yeah, you have to do what's called a double-blind placebo-control trial, where the clinician and the patient do not know who's getting the drug and who's not, and who's getting the placebo. Which sounds a bit, of a funny thing to do, but that's the way these things are done. As Lynn said, it's a phase 3 trial. This involves hundreds of patients and more than one centre, and obviously the cost implications will be much higher. So basically, we need funding to make this happen. We've got the team, we've got the setup, we've proved it worked. We've sorted out all the logistics, we've got all the equipment, we've got the backing of Hologic for this. So basically, all we need is the funding to make it happen.
Yeah.
You mentioned that you want to that you need to do the study in more than one center. Are you looking to keep the study in Nairobi, or are you looking to branch out into other countries maybe?
We would love to keep it in Nairobi. In fact, that would be our greatest hope. We have other potential sites. For instance, our Dean of Medicine here has very strong connections in Kampala, in Uganda. So there are possibilities there. We also have a colleague in Johannesburg who's very, very interested, Dr. Cindy Fernhaber. She's very, very interested in coming on board. So basically, we have the sites. And of course, the African location is obviously, we think it's very important because of the importance of this particular disease to women in sub-Saharan Africa. To us, it's a win-win.
Great. So for anyone watching who would like to contribute in any way, how can they get hold of you?
There's a small charity in the UK. I mentioned them before, called the Caring Cancer Trust. They have a Virgin Giving account which qualifies for gift aid and all kinds of things in the UK. And they have said basically that we can use this account as a source for donations. It's very straightforward. You just go onto their website, which is Caring. If you look up Caring Cancer Trust, they're based on the Isle of Wight. You'll find the website. It comes up in the first 3 hits on Google. And they have a donate button which anybody can donate through, which would be absolutely fantastic, because they've already agreed that any of the funds that come through from this will be put straight towards this for this purpose, towards the phase 3 trial.